and welcome to A Sound Constitution, here on CHLY 101.7 FM, a show where we focus on health topics that are important to our community. This year's team is made up of 6 VIU nursing students, and our goal is to demystify health issues and address common misconceptions by sharing evidence-informed information from a variety of reliable resources. All information provided on our show will be available in our show notes on our Facebook and Instagram pages. We want to remind our listeners that the information presented in this show is for educational purposes only and does not replace the advice of your primary healthcare professional. If you have questions or concerns about what's being discussed, feel free to reach out to us on Facebook at A Sound Constitution, on Instagram at CHLY A Sound Constitution, or email us at asoundconstitution@gmail.com.
We begin today by acknowledging that we are gathered on the unceded and traditional lands of the Snuneymuxw people, whose rich cultural history continues to inspire and guide us. Our broadcast also extends into the territories of the Coatson and the Sliaman nations. We are deeply thankful for the Snuneymuxw people's enduring connection to this land and for the opportunity to live, learn, and work here today. We make this acknowledgement with a commitment to honor and respect Indigenous cultures, traditions, and histories, and to actively participate in the ongoing work of truth and reconciliation. For more information on the ongoing reconciliation work and land acknowledgement practices of the Snuneymuxw people, we invite you to visit our Facebook, Instagram, and YouTube pages. Hello, and welcome back to A Sound Constitution on CHLY 101.7 FM. I'm Rebecca, and I'm so glad you're here with us. Today's episode is a big one, because British Columbia just made history. BC is the first province in Canada to introduce legislated nurse-to-patient ratios, a change that many in healthcare have been waiting decades to see. But what exactly does that mean? And why does it matter now? Across the province and really across the country, nurses are burning out. Emergency rooms are closing, wait times are growing, and patients are spending more hours in hallways than in hospital beds. The system is strained, and everyone feels it. The idea behind nurse-to-patient ratios is simple. When nurses have fewer patients to care for, care quality improves, safety increases, and patients recover faster. But implementing these ratios isn't just about numbers on a policy sheet. It's about what those numbers represent: time, safety, and humanity. Time to listen, time to comfort, time to catch small changes before they become big problems. In today's episode, The Human Side of Ratios, Nurses, Patients, and BC's Plan, we will unpack what these ratios mean for our healthcare system. We will explore what nurse-to-patient ratios actually are and why BC is adopting them, what they promise for nurses, from safer workloads to better retention, and most importantly, what they mean for patients and families, from safety and dignity to trust and recovery. You'll also hear insights from studies, global evidence showing how these policies can transform healthcare systems when done right, because this isn't just a story about healthcare reform, it's about what happens when we finally decide that safe care and sustainable work are non-negotiable. So stay with us while we talk through the history behind BC's nurse-to-patient ratio policy and why many believe it's one of the most significant steps forward for both nurses and patients in decades. You're listening to A Sound Constitution on CHLY 101.7 FM. Let's start at the beginning and talk about what we actually mean when we say nurse to patient ratios. Ratios are the maximum number of patients that one nurse is responsible for during a shift. They are set to protect both patient safety and nurse well-being. On a typical medical surgical unit, that usually looks like one nurse caring for 4 patients. In an intensive care unit where patients are critically ill, the ratio is 1:1. And in the emergency department, it can vary, but the principle is the same. The sicker the patients, the fewer each nurse should be assigned. When those ratios are exceeded, when a nurse is suddenly responsible for 6, 7, or even more patients, something has to give. Care gets delayed, breaks are missed, and the compassion that is at the heart of nursing is put at risk. That's why ratios aren't just a policy or a number on a staffing sheet. They are about protecting the time and space nurses need to be nurses. Because nursing isn't only about starting IVs or giving medications on time. It's about noticing when someone is scared, when a patient needs reassurance, or when a family needs someone to explain what's happening. Safe ratios make room for those moments, the human ones, that truly define care. And this is exactly why I wanted to include Christy Watson's TED Talk, What Nurses Can Teach Us. Christy is a nurse and an author who has spent years reflecting on what makes nursing unique. In her talk, she shares that nursing is really about compassion, the countless small acts of presence, kindness, and dignity that go far beyond medical tasks. I'm including this talk here because it gets to the heart of what ratios are really about. We can look at charts, graphs, and studies all day, and we should because the evidence is important. But Watson reminds us of the other side of the story, the soul of nursing. Without safe staffing, nurses don't have the time to sit at the bedside, to listen, to comfort, to simply be there, and that's what the patients remember most. So, as you listen to Christy Watson's words, I want you to think about this. Ratios are more than numbers. They are a promise that every patient will receive not just medical care, but human care. And they are a safeguard that nurses will have the time and energy to keep giving that compassion without burning out. Here's Christy Watson, What Nurses Can Teach Us.
I am sick and tired of compassion. I wasn't always like this. When I started my nurse training at the age of 17, I didn't think much about compassion at all. I thought about resuscitation and saving lives and cracking chests. I thought a lot about television programs like ER, and I thought a great deal about George Clooney. But nursing taught me pretty quickly that saving lives is about a lot more than cracking chests. In 2018, I left the nursing register and I am a writer and professor of medical and health humanities. And my research over the last few years has been about compassion and empathy and kindness and what it means to be human. And central to the idea of all my work is that compassion is the most important thing of all. And yet, I realized that during my years as a hospital nurse, particularly in intensive care, I felt a bit burnt out, apathetic, and sometimes even indifferent to extreme suffering. I was experiencing compassion fatigue. Pain and trauma, like viruses, can be extremely infectious, and nurses and other healthcare workers, they swallow suffering every single day. Indeed, the word compassion comes from Latin compassione, which means to suffer with, suffering together. And there's only so long you can do that for, if you do it right, without becoming a little bit numb. I felt a bit numb. And then came the pandemic. I remember being on a flight once, coming back from Kenya, and there was an announcement on the tannoy. Is there a doctor or nurse on board the plane? I looked around. Nothing. And then the announcement again, is there a nurse or doctor on board the plane? Please make yourself known to the cabin crew. Now, I had no intention of making myself known. In fact, I slid down my seat. I wanted to drink my gin and tonic and read my magazine in peace. But the announcement again, and this time the voice was urgent. Is there a healthcare worker on the plane? Please, we need help. We need help. And so I slowly and reluctantly raised my hand. During the first peak of this pandemic, I slowly and I reluctantly raised my hand again, and I returned to clinical work for a short time, and I found myself the lead nurse for compassionate care in one of the field hospitals that had been hastily set up in just 9 days as a COVID ICU. We were told our function was to save as many lives as possible. And it quickly became very apparent with this awful, awful disease that we weren't going to save anywhere near as many lives as we wanted to. And compassion became our central aim. Compassion, we realized, is how history will judge us. And it's how history should judge us. And we weren't alone in our thinking. There was a time at the beginning of this, a hot moment when the world felt alive with compassion. It's like we were shaken awake. How quickly we forget. 1 minute people were on their doorsteps, they were banging pots and clapping for carers and delivering food parcels to their neighbours who were shielding, and the very next moment, people's curtains closed. Everyone shuffled past each other, heads down, no eye contact. Everyone turned inwards, we all did, just trying to process our own pain. And a collective numbness swept through the world. It is no surprise. We are bombarded with tragedy. The COVID-19 pandemic uncovered the other pandemics that already existed: loneliness, inequality, injustice, violence, racism, mental illness. The events in Afghanistan, they're hard to even think of. And the existential threats of climate change, we are now told, is code red for humanity. We are tired. We are overwhelmed. And we're saturated with images of devastating suffering. And so sometimes it's all we can do to turn off the relentless news and watch Love Island instead. Maybe that's just me. But it is possible to recover from this compassion fatigue. We must recover from it. I know it's possible because I did. Shortly after returning to clinical work, I remembered something really, really important. I remembered what my patients had taught me, and I remembered what it means to be a nurse. In all my years in hospitals, I never once met George Clooney. But I did meet lots of patients like Betty. Betty was elderly and frail, and she was alone, and she was lying on a trolley in a corridor outside accident and emergency. She'd come into the hospital with chest pain and hypothermia. I did a 12-lead ECG, some observations, some blood tests, and we couldn't find anything at all wrong with Betty. So I got this Bear Hugger machine, which has white billowing fabric to warm her up. And I made her a sandwich and a cup of tea, and I just sat with her and held her hand. And then she told me about Stan. She told me Stan, her husband of a lifetime, had died in the hospital 2 weeks before. And she described her heart pain, not chest pain. She told me how they had danced and how the fabric from the Bear Hugger machine reminded her of the parachute silk from her wedding dress, and how time flies. And she said that I'd saved her life, and of course I'd done no such thing. I just sat with her a while and I held her hand, But it was impossible to tell where Betty's hand ended and where my hand began. And nursing exists in that space. We exist in that space. What a privilege to hold the hand of a person at the frailest, most extreme and significant moments of their life. To be a nurse. Nurses remind us that we are not alone, not even now. But of course, they do a lot more than hold hands. Nurses are safety-critical, rigorously trained professionals. They are scientists and researchers and leaders and entrepreneurs and artists, and they're clinical experts. They weave around our world, caring for people in every setting you can imagine. School nurses, district nurses, practitioners working in mental health and learning disability settings, forensic nurses, military nurses, nurses working in prisons, on homeless healthcare teams, in hospices, with looked after children. There are even nurses working behind the scenes on Love Island. The World Health Organization estimates there are 27.9 million nurses globally, 27.9 million individuals who have, despite personal risk, placed compassion at the center of their universe for us. Nursing is a language with many different accents, but it's a universal language too. It's a kind of faith in itself with compassion at its core, a belief and respect in every single individual's worth, regardless. If how we treat our most vulnerable is a measure of our society, then the act of nursing itself is a measure of our humanity. And we all are now thinking during this time of great suffering about our humanity. Who are we? Who are we meant to be? COVID has given all of us the time for radical change and the chance for radical change. But we must shake ourselves awake again and remember the action we saw at the beginning of this pandemic when we glimpsed our capacity for grace, for tolerance, and for love. We can remind each other of our potential by listening, really listening, thinking of other families as well as our own, by helping those who need help in practical ways and building inclusive communities. Betty was right. Nurses are right. Compassion cannot cure us, but compassion can save us regardless. The word compassion comes from compassionem, meaning to suffer with, but the word suffer comes from feeling, to feel keenly. In this age of isolationism and division and hatred, it is not feeling anything that we all must fear. In order to turn outwards, we need to feel all the feelings and remember our capacity, our incredible human spirit. It's time for us to raise our hands. Rumi was a 13th century Afghan poet. In my opinion, he was the greatest poet in all of history, and I'm going to leave you with his words, more relevant today than perhaps ever. I know you are tired, but come. This is the way. Thank you.
That was Christine Watson's TED Talk, What Nurses Can Teach Us. In her TED Talk, What Nurses Can Teach Us, Christine Watson highlights the deep compassion, emotional intelligence, and humanity that define nursing. She shares powerful stories that influence how nurses support patients and families through both joy and suffering, emphasizing that nursing is as much about kindness and connection as it is about clinical skill. Watson calls for greater recognition of the emotional labor nurses provide and how their values of empathy and care can transform healthcare and society. Building on Watson's message, our episode explores how nurse-to-patient ratios directly impact the quality of care and the emotional well-being of nurses. The very compassion and connection Watson describes depends on safe, sustainable workloads. So what do these new ratios actually promise? What they could mean for the nurses on the floor and for the patients and families who depend on them? Next up is Anna, who's going to take a closer look at the promise behind BC's new nurse-to-patient ratios, what they mean for nurses and patients, and for the future of healthcare in our province.
I'm Anna. Today, we're diving into a major shift in BC's healthcare system, the rollout of minimum nurse-to-patient ratios. We're going to look at what's promised, what this means for nurses and patients alike, and where real-world bumps may lie. So first, what do we mean by ratios? In British Columbia, the provincial government and the BCNU, or the BC Nurses Union, have agreed on a minimum nurse-to-patient ratio, often abbreviated as MNPRs. These minimum staffing formulas are created so that each shift on each hospital unit or other care setting, there is a target maximum number of patients a nurse is responsible for. The aim of this is to make staffing safer and more predictable. According to the government's FAQ, MNPRs represent the minimum number of nurses deemed necessary to care for the number of patients on a given unit. Madison will get into that a little bit more later on in the show. This matters because nurses, when overloaded, risk burnout, make more errors, and leave the profession. And patients risk delayed care, have more complications, worse outcomes. And in fact, the BCNU says BC will become the first jurisdiction in Canada to have this standard in hospitals, a significant milestone. Now, just want to let you all know that one more definition you'll hear me use is the term med-surg. It's short for medical surgical. It's a term used for a type of nursing. It's the hospital units where patients are being treated for general illness, medical, or recovering from surgery, surgical, and not specialty units like the intensive care unit or a completely non-hospital setting. For example, a med-surg unit may care for someone recovering from abdominal surgery or someone who is admitted for pneumonia, rather than someone who might be in a trauma ward or in the intensive care unit. Why I mentioned med-surg? Because many of the ratios announced apply first to med-surg units. For example, the 1-to-4 patient ratio in certain units applies to med-surg. Let's talk about what that means for you if you're a nurse or you're becoming one. One of the core promises is that nurses won't routinely have to cover too many patients. When a ratio is set and enforced, you'll know your shift will assign you a manageable number of patients. Overwork and moral distress lead nurses to leave the profession. According to BCNU's 2024 survey, many nurses reported unsafe working conditions. For example, the survey found that a high percentage of nurses reported violence, abuse, and unsafe workloads. Better staffing means fewer emergencies, less firefighting, and more time for the care you were trained to give. For students and new grads, this is key. If nurses are overloaded, they have a harder time teaching, supervising, or helping students reflect. Having more time with the assignment of less patients fosters better learning environments. And when you walk off that shift feeling like you've delivered real care, not just triage mode because you are overworked, because your patient load is too heavy, it makes a difference staying in the field over the long term. Now, if we flip the lens, what does this promise mean for patients and their families? Studies from varied jurisdictions show that when nurse-to-patient ratios worsen, i.e. each nurse has more patients, the risk of adverse events, complications, and even mortality increases. For example, the campaign Ratio Save Lives from the BCNU cites that patient mortality increased about 16% for every patient in a nurse's assignment in one large study. When nurses aren't stretched thin, they have more time to listen, assess, educate, and respond. That means fewer delays, fewer missed tasks, more consistent care. A minimum ratio sets a floor, not perfect care, but safe care. It helps ensure that you won't always get the "we're so short, so we'll do less" model. Better staffing means fewer complications, potentially shorter hospital stays, fewer readmissions, which ultimately saves the system money and improves care for everyone. The government of BC lists these as expected effects. So for patients, the promise is not just more nursing, it's better nursing, more time, more attention, fewer risks. So where did this idea come from? It's not brand new. Other jurisdictions, for example, California, implemented the nurse-to-patient ratios back in 2004. Australia has also similar standards. Oregon is working on implementing minimum nurse-to-patient ratios as well. The BC government FAQ site notes that the province looked to these experiences as a model. In BC, in April 2023, the Nurses Bargaining Association and the Ministry of Health signed on to implement nursing ratios in hospitals, long-term care, assisted living, and community settings. The province then committed $750 million over 3 years, 2023 to 2026, to fund the implementation. In September 2024, the province announced further ratios for emergency departments, OR, maternity, and alternative care units. This is a policy shift from reactive staffing, aka we'll fill in the gap when it breaks, to planned staffing. We build safe teams ahead of time. An important caveat is that these are minimums, not maximums, and they do not reduce the need for professional judgment. The policy says that units may need more nurses when patients are unstable or acuity spikes. So let's dig into some numbers so you can see how this plays out in practice. The BCNU FAQ lists phase 1 ratios in a general med-surg unit as 1 nurse to 4 patients around the clock. For other areas such as rehabilitation, during the day, 1 nurse to 5 patients, during the night, 1 nurse to 7 patients, and a palliative unit, 1 nurse to 3 patients, an intensive care unit, it's 1 nurse to 1 patient. The plan is for the full suite of ratios to be phased in over approximately the next 4 years from 2023 onward. A survey of nurses found that 68.3% said they did not have enough staff, and 77.3% said workloads felt unsafe in a BC context. These high numbers show there's a baseline problem. So let's translate. If previously a nurse had 6 to 7 patients on a med-surg unit, moving to 4 patients is a big change. That means more oversight, more time for mentorship, more time to be proactive about patient care. These numbers show promise, but the work of implementation remains large. Now we'll shift on to how this gets done and where concerns remain. The promises are that each health authority in BC will have a joint regional implementation committee, otherwise known as the JRIC, with equal representation of BCNU and employer sides to guide planning and rollout. Implementation will begin with hospital-based acute care settings such as med-surg units, emergency units, and then expand to long-term care, assisted living, and community care. Rolling out across all settings takes time. Some units may lag behind. Recruitment and workforce, you need enough nurses to fill these ratios. The government estimates that 8,000 new nurses are required. In rural and smaller sites, smaller hospitals and remote facilities may face unique constraints, fewer staff, higher acuity swings, multi-role assignments. The government does have a working group to address this. Even with ratios set, patient needs vary. The policy allows for temporary ratios being exceeded when needed due to acuity and variability. Setting the ratio is one thing, but making sure it's enacted daily is another. That's led via reporting and oversight requirements. In short, the structure is in place, but the challenge is converting it to everyday shifts in every hospital, long-term facility, and community site. If we take a closer look at rural and smaller site facilities, often overlooked yet critically important, in these settings, nurses may shift between multiple units, for instance, med-surg, emergency, long-term care, perinatal, in the same day. Fixed 1 nurse to 4 patients may need adaptation. Recruitment is also harder in rural areas. Retention is harder. Access to float pools, coverage for leave, and support at night may be stretched. Patient acuity may swing wildly. 1 day routine, next day trauma. Staffing flexibility is needed. The BC Government Advisory Note states many rural and remote facilities have unique needs when it comes to implementing these ratios. A working group will release recommendations to ensure nurses and patients reap the benefits while recognizing their unique needs in these remote areas. As a nursing student or future nurse, this means if you work in a rural site, ask your site's leadership. What's our ratio plan? How will we handle variable acuity? How will staffing and breaks work? The promise is province-wide equity. The risk is that remote areas may lag or adapt differently, and it's definitely something to monitor. Beyond individual shifts, what does this mean for the bigger system in BC? Retention and workforce stability. If fewer nurses leave, fewer vacancies, less reliance on expensive agency nurses. It is increased cost effectiveness. It costs money to hire more staff, but losing staff and managing poor outcomes costs even more. BC is becoming the first Canadian province to set these ratios, and it's a signal that this province is taking staffing seriously. The policy directive states ratios will be reviewed every 3 years, so data will be collected quarterly, nurses' outcomes, patient outcomes, system outcomes. So there is plans for continuous improvement. And to meet staffing levels, BC is investing in education seats, retaining internationally educated nurses, and professional development incentives. So in the long run, this isn't just about now, it's about shaping the next decade or so of nursing in BC, the safety of care and making healthcare sustainable. The following are some email addresses if you have questions about these ratios from the BC government website. For policy and implementation questions from the ministry, npradmin@gov.bc.ca. So that's npradmin@government.bc.ca. The General Ministry inbox, hlth.health@gov.bc.ca. So to wrap up, the minimum nurse-to-patient ratios being rolled out across BC promise better balance for nurses, safer and more dignified care for patients, and a stronger healthcare system for all of us. The evidence is clear. Fewer patients per nurse equals better outcomes. We know the goal. The real question is how well will we make it happen, especially in rural and smaller site settings. Implementation is underway, budgets are committed, committees are formed, but this is not fully done yet. It must be monitored, adapted, and enforced. Just a reminder, this is a sound constitution. Up next, a quick message from the BCNU about why ratios save lives, then I'll hand you back to Rebecca. Stick with us. It's Anna signing off for a sound constitution.
When the nurse-to-patient ratio isn't right, our healthcare system becomes overwhelmed. But when we add more nurses to the equation, they can spend more time with each patient, providing the care they need and deserve. This results in reduced mortality rates, shortened hospital stays, fewer readmissions, and less nurse burnout. The math is simple. Better nurse-to-patient ratios create a better healthcare system for all of us. Learn more at ratiosavelives.ca.
Okay, so now that we've explored what ratios are and what they promise, let's pause and take a closer look at the evidence behind them. This is our academic resource spotlight, where we bring in research and policy context to help us separate hopes from facts. When it comes to nurse-to-patient ratios, there's actually a growing body of international research that shows clear links between safer staffing and better outcomes, not just for patients, but for nurses and the healthcare system as a whole. And most recently, British Columbia has contributed its own study to this global evidence. Let's start with a new study from BMJ Open, published in 2025 by Lassiter and colleagues. This was an observational study right here in BC, the first Canadian province to adopt mandated nurse-to-patient ratios. The researchers wanted to know, does staffing actually make a difference in hospitals across British Columbia? They looked at hospital data across the province, including nurse surveys, staffing numbers, and patient outcomes. What they found was striking. Hospitals with better nurse staffing ratios had significantly better patient outcomes. For example, patients in better staffed units had lower in-hospital mortality and fewer complications. Nurse reports confirmed the difference. Nurses working in better staffed settings were more likely to say they had time to provide quality care and less likely to report missed care due to time pressure. And importantly, the effects were province-wide, not just in large urban centers. The study showed that across BC, from major hospitals to smaller sites, safer staffing levels translated into better care. The takeaway is clear. Nurse-to-patient ratios are not just a political promise, but a measurable factor that improves quality, safety, and nursing practice. So now BC is not alone at looking at this issue. One of the leading researchers in this field is Linda Atkin from the University of Pennsylvania. Her work has spanned multiple countries and thousands of hospitals. In a landmark 2014 study, Atkin and colleagues examined nurse staffing across Europe. They found that every additional patient added to a nurse's workload was associated with a 7% increase in the risk of hospital death within 30 days of admission. In the United States, Atkin's research showed similar results. States with mandated ratios, like California, have seen lower patient mortality, fewer readmissions, and better nurse retention compared to states without them. These findings line up directly with what we're seeing in BC. Better staffing saves lives, protects nurses from burnout, and improves the overall efficiency of care. It's not just theory, it's been proven again and again. But research alone doesn't change policy, though. This is where advocacy comes in. The BC Nurses Union has been at the forefront of pushing for mandated ratios for years. Nurses on the ground have long reported unsafe assignments, missed breaks, and moral distress from being unable to provide the care they know their patients deserve. In 2023, the BC government finally responded with a commitment to implement legislated nurse-to-patient ratios, the first province in Canada to do so. This policy shift was a direct response to years of advocacy combined with mounting research evidence that staffing is not just a workplace issue, but a patient safety issue. Of course, policies are only as strong as their implementation. The promise is there, but the rollout will need to be closely monitored, especially in smaller communities. And that brings us back to our local context. On Vancouver Island, staffing challenges can look very different from those in large metropolitan hospitals. In rural and remote communities, recruitment and retention are constant struggles. Nurses may be covering multiple roles, working longer shifts, or carrying heavier workloads because there simply aren't enough staff to go around. The question we have to ask is, will mandated ratios benefit these communities in the same way they benefit urban hospitals? The evidence from BC's BMJ Open suggests yes. Staffing matters everywhere, but the challenge will be ensuring equity. That means supporting rural hospitals in recruitment, providing incentives for nurses to practice outside of big cities, and making sure ratios don't just exist on paper, but are actually met in practice. On the island, this could mean fewer sick calls, more stable scheduling, and safer discharges for patients. It could also mean that nurses finally feel like they have the time and support to do what Christy Watson reminded of us earlier, those small but essential acts of care that define the profession. So, to sum it up, the research is clear. Better ratios save lives, reduce burnout, and improve care. The advocacy has worked. BC is leading Canada in legislating staffing ratios. The challenge now is implementation, making sure both large urban centers and smaller rural hospitals see the benefits. Well, that was our academic resource spotlight. When we come back, we'll move on from research to possibility, looking at the broader hopes and promises of mandated ratios, not only for nurses, but for patients, families, and the healthcare system as a whole.
Hello everyone, my name is Madison and you are listening to A Sound Constitution on CHLY 101.7 FM. So far, you have been briefed on BC being the first Canadian province to legislate nurse-to-patient ratios and what this means for nurses. But what does this mean for patients? When we think about healthcare, we picture our patients, the faces in hospital beds, loved ones waiting at the bedside, or families hoping for good news. But behind every patient experience is a team of nurses, the steady heartbeat of healthcare systems. Across Canada, hospitals are struggling with staffing shortages, nurse burnout, and job turnover, challenges that didn't start with the pandemic, but that have been magnified by it. Today, we're exploring what happens when nurse-to-patient ratios are improved and why the benefits reach far beyond the nursing profession and affect the lives of patients. Because when nurses are supported, patients thrive, families feel heard, and our healthcare system becomes stronger and more sustainable. Let's start off with a reality check. Imagine you're in a busy emergency department, the waiting room is full, patients are growing restless, and nurses are juggling multiple complex cases running around from room to room. According to a 2025 study by Lassiter and their colleagues, they found that hospitals in British Columbia with nurse-to-patient ratios, where there are more patients per nurse, had higher rates of preventable adverse outcomes and lower patient safety overall. Their research also highlighted that better staffing not only improved patient safety, but also increased nurse job satisfaction that reduced job turnover. Now, you may be asking yourself, why does this matter to patients? Because every missed medication, every delayed discharge, and every moment a patient's call bell goes unanswered directly impacts recovery of our patients and the quality of care nurses are able to provide. In a 2020 study conducted in British Columbia and Alberta, Cho and their colleagues found that inadequate staffing was linked to something called missed care. Tasks like patient education, medication administration, and timely assessment either being skipped or delayed. These missed moments can quickly become longer hospital stays, higher risk for complications, and ultimately poorer outcomes for patients. Protected nurse-to-patient ratios are a pressing matter that is necessary to the positive evolution of our healthcare system. Now, let's dive into what this means in rural versus urban medical settings. In urban centers, hospitals usually have access to larger pools of nurses, specialized units, and more resources. But rural facilities face a unique challenge: limited staff, fewer recruitment incentives, and higher turnover. When a single nurse calls in sick in a rural hospital, it can mean an entire unit shift is short-staffed. According to the Canadian Federation of Nurses Union 2022 report, Sustaining Nursing in Canada, rural and remote hospitals are disproportionately affected by staffing shortages. These shortages lead to temporary closures of emergency departments, increased wait times, and delayed discharges. All of these directly affect patient access and safety. On the other side of the picture, urban emergency departments, overcrowding continues to strain the system. A 2013 paper by Affleck and their colleagues published in the Canadian Journal of Emergency Medicine identified that emergency department overcrowding, often a symptom of staffing and bed shortages, leads to prolonged wait times, increased patient adverse outcomes, and diminished quality of care. Whether in a small town hospital or a metropolitan trauma center, this issue remains the exact same. When nurse staffing is inadequate, patient care pays the price. So what kind of strategies can really make a difference in our healthcare systems? How do we decrease the stories we are hearing more and more every day? From "I waited in the emergency department for hours on end" to "the nurses looked overworked." What can we do about it? Retention is the key. When experienced nurses stay, patients benefit from this continuity, their expertise, and are provided safer care. To reiterate an issue mentioned previously, in a 2019 study by Chen and their colleagues found that high patient-to-nurse ratios increased burnout and job dissatisfaction that directly contributed to nurses' intention to leave their jobs. But here's the chain reaction. When those nurses leave, hospitals face the consequences of sick calls, have heavier workloads for those who remain, and reinforce this cycle of burnout. On the flip side, when staffing improves, the benefits multiply. In a landmark 2021 study by McHugh and colleagues, They evaluated nurse-to-patient ratio legislations in Australia. After mandated ratios were introduced, hospitals saw reduced patient mortality, fewer readmissions, and shorter lengths of stay. This study directly highlighted how patients not only survived more health-related deficits, but they recovered faster, and healthcare systems saved money through reduced complications and hospital days. Those are outcomes that affect every taxpayer and every family who depends on the healthcare system. As you listen to this episode, you may have been asking yourself, what is the ideal ratio? In a 2025 study by Have and their colleagues, they looked at over 600 nurses in British Columbia's medical surgical units, and they found that a ratio of 1 nurse to 4 patients led to the best outcomes for both quality of care and nurse well-being. Once that ratio climbs higher, say to a ratio of 5 or 6 patients to 1 nurse, nurses reported significantly more emotional exhaustion and higher rates of undone tasks. We have been focusing this nurse-to-patient ratio conversation primarily on the effects on Canadian healthcare systems. But as we may know, these effects aren't limited to Canada. In Driscoll and their colleagues' 2018 systematic review and meta-analysis, they found that higher nurse staffing levels across multiple countries were consistently associated with lower patient mortality, fewer medication errors, and lower infection rates. Similarly, Aiken and their colleagues' 2018 study linked better staffing and education levels with reduced hospital mortality in Canadian and European hospitals. It is evident that across many studies and settings, the pattern is clear. When staffing improves, patient outcomes follow. Now, I've thrown a lot of numbers and statistics at you, but this issue isn't just about the numbers. It also focuses on the relationships between nurses, patients, and families. When nurses aren't rushing between too many patients, charting, and tasks, they have time to listen, to explain discharge instructions clearly, and communicate and establish relationships with families. Research consistently shows that patients and families who understand their care plans are less likely to be readmitted and more likely to adhere to medication schedules and follow-up appointments. During the COVID-19 pandemic, as we saw on the news and heard stories, nurses were stretched to their limits. In a 2023 qualitative study by Menard and their colleagues, they followed nurses 1 year after the first wave and found patterns of exhaustion, moral distress, and disconnection. But they also found resilience. Nurses described feeling forgotten, overworked, and undervalued, yet they persevered and continued to show up for patients every single day. Imagine what happens when that same level of dedication is properly supported by safe staffing ratios. Families receive more updates, patients are discharged with confidence, and nurses can provide the holistic care that they were trained to deliver. Let's shift the conversation to a systems perspective. Safe staffing is one of the smartest investments a healthcare system can make. As we stated, when nurse burnout decreases, retention improves. When retention improves, hospitals spend less on recruitment, training, and overtime coverage. A 2020 global meta-analysis by Wu and their colleagues found that poor staffing and high workloads were among the strongest predictors of burnout and intent to leave. Burnout doesn't just cost nurses their health, it costs healthcare systems millions in turnover and lost productivity. Similarly, McHugh and Ma's 2024 research found that hospitals with better staffing and work environments had lower rates of nurse burnout and job dissatisfaction, factors that directly translate to better patient safety and care quality. When nurses stay healthy and engaged, the system sees fewer sick calls, less agency reliancy, and more consistent care. That means safe discharges, shorter waits, and fewer preventable readmissions. Ultimately, safer staffing isn't just a workforce issue, it's a patient safety policy, an equity issue, and a financial imperative. Countries around the world are recognizing everything we just discussed. Australia, parts of the United States of America, and parts of the United Kingdom have all adopted legislated nurse-to-patient ratios. What are the results? Improved nurse well-being and measurable improvements in patient outcomes. Yet, here in Canada, staffing levels still vary widely by region and hospital. I've seen it myself in as little of a distance as Nanaimo is to Port Alberni. In rural areas, the shortage is especially severe. Nurses are often required to cover multiple units or work mandatory overtime that increases risk and stress. The Canadian Federation of Nurses Unions argues that national-level staffing standards could create a baseline of safety across provinces. Their recommendations call for evidence-based ratios, improved data collection, and dedicated funding to support retention and mentorship programs. Implementing these measures could bring the kind of stability that benefits everyone: nurses, patients, families, and healthcare administrators alike. At the end of the day, this conversation isn't just about numbers or policies. It's about people. The population that we all work, live, and learn alongside each and every single day. When nurse staffing is safe, patients get better faster, families feel informed and reassured, hospitals operate more efficiently, and nurses, the people who spend the most time at the bedside, are able to do what they do best: provide compassionate, competent, and life-saving care. According to many of the studies we talked about today, staffing improvements are one of the few interventions that consistently enhance both nurse well-being and patient safety. So the question becomes, how can we afford to not act? Because safe staffing isn't just good for nurses. It's the foundation of a healthcare system that truly works for everyone. For more on this topic, you can find all links on the information provided in our show notes. I encourage everyone listening to ask yourself, what does a healthcare system look like when it's thriving? What are wait times like? How do the stories we hear about hospitals change? And how do the lives of the healthcare workers and patients you know improve? My name's Madison. Thank you for listening, and once again, you are listening to A Sound Constitution on CHLY 101.7 FM.
As we wrap up today's episode, we have taken a closer look at what mandated nurse-to-patient ratios really mean, not just in policy, but in practice and in the everyday lives of nurses and patients. To recap this episode, Anna started us off by breaking down what these ratios actually are and why British Columbia is moving towards them. She explained how these new standards are designed to protect both patients and nurses, setting clear limits that help ensure care is safe, sustainable, and fair. It's a big step toward creating a healthier work environment and restoring balance in our hospitals. Madison then took us into the research, showing us what happens when staffing levels are too low and what changes when they're right. Studies by Eichen, Leicester, and others consistently show that when nurses have too many patients, outcomes worsen. Burnouts rise, mistakes happen, and care is missed. But when workloads are manageable, everything improves. Nurses stay longer, patients recover faster, and overall safety increases. And tying it all together, we reflected on Christine Watson's TED Talk, What Nurses Can Teach Us. She reminds us that nursing isn't just about clinical skill, it's about compassion, presence, and human connection. Those moments of kindness and empathy that make care meaningful are only possible when nurses have the time and capacity to truly see their patients. Mandated ratios are at their core about protecting that space, the space to notice, to listen, and to care fully. They are a recognition that safe staffing isn't a luxury, it's essential to preserving the heart of nursing. As BC takes these steps forward, we're entering a hopeful time, one that acknowledges the value of nursing and the emotional labor that goes into it. It's a move towards a future where both nurses and patients can thrive. I'm Rebecca, and this has been A Sound Constitution. Thanks for listening.
Thank you for listening. For details and show notes from today's episode, or to follow along on what's coming up this season, check out our Facebook page, A Sound Constitution, or our Instagram at CHLY A Sound Constitution. If you missed today's episode, or if you'd like to listen to one of our previous episodes, check us out on Spotify or YouTube at A Sound Constitution. We want to remind our listeners that the information presented in this show is for educational purposes only and does not replace the advice of your primary healthcare professional. Thanks again, and we hope you have a wonderful rest of your day.